hip dislocations and femoral head fractures. This is from the OTA Core Curriculum Resident Lecture Series version 5. Slides are by Dr. Thomas Moore, Jr. And I'm Saqib Rahman narrating. We already covered the first part of the video in which we went through the anatomy, the blood supply, mechanisms, radiographic evaluation, etc. Now we're going to focus a little bit more on classification and also talk a little bit about indications. So there's an AO-OTA classification, and it is shown here. I'm not going to run through this completely, but the femoral head is, the femur is bone number 3, femoral head is 1, so it's a 31. So 31, C1 is a split fracture, C2 is depression, and associated dislocations are coded using a universal modifier in square brackets, if you go back to the previous slide. So it's a little bit of a confusing classification because it's a little different than many of the other ones we use in the AO classification to some extent. So here are the C1s, where you have avulsion, infrafoveal, suprafoveal fracture. We'll come back to that concept a little later. C2s are the sort of impaction or depression injuries. The Thompson and Epstein classification of posterior hip dislocations are as follows. Type 1 is a pure dislocation with or without a minor fracture. Type 2 is a dislocation with a single large posterior wall fragment. Type 3 is dislocation with a comminuted posterior wall. Type 4, dislocation with acetabular floor or transverse posterior wall. And then type 5 is a dislocation with a femoral head fracture. The Pipkin classification is probably used most frequently, certainly in North America. Type 1, as shown in the top left, is caudal or inferior to the fovea, so an infrafoveal femoral head fracture, whereas type 2 is a suprafoveal femoral head fracture, as shown below here. Type 3 is a femoral head fracture with associated femoral neck fracture, and then type 4 is a femoral head with associated acetabulum. So with the Epstein classification, there's also anterior hip dislocations where type 1 is superior, type 2 is inferior. Now let's talk about treatment, right? So reduction, timing, we said this before, a dislocated hip dislocation or native hip, because with the total hip, it's also urgent, but you do not have the blood supply to worry about. You're not going to get osteonecrosis because there is no femoral head, right? So when we say native hip, it's a term used to talk about just a regular hip dislocation. So emergent reduction can help restore blood flow through the kinked or compressed vessels. We talked about this in the previous video. Overall rate of osteonecrosis after hip dislocation is 2 to 10%. If you wait too long, the risk goes up considerably. So many have advocated for pretty urgent, within 6 hours reduction. That requires proper anesthesia. So you do have to get the patient reasonably sedated. Sometimes you have to do general anesthesia. So patient should be fully relaxed. You can certainly do this in the emergency department in order to get to it quickly. But if it's not happening and you're in the OR or have to go to the OR, then you'll have to do that emergently. For instance, ER may not be able to give adequate sedation and relaxation. There may be other things going on. Maybe the patient's already having to go to the operating room. The Alice maneuver, it's very commonly done. Patient supine. It's a traction, counter-traction technique. So you see there's 2 people involved here. One providing downward force on the ASIS. You can see 2 hands on the pelvis to stabilize the pelvis, while the person doing the reduction flexes the hip and knee and then provides a longitudinal traction with gentle rotation to get the reduction. Other techniques, for instance, the Stimson gravity maneuver, less commonly done, shown here. The Bigelow maneuver, shown here. Other examples are the East Baltimore lift, which require multiple assistants, and to some extent is somewhat similar to the Alice or Bigelow maneuver. There are many other reduction techniques, as shown, and even these. Here's the East Baltimore lift, the Lefkowitz maneuver. So nice illustrations of these techniques. The anterior, and it's probably good if you want to go on YouTube and check a video of some of these techniques. You will find them as well as on the OrthoClips website. The anterior hip dislocation can be reduced with the Walker modification. So for inferior dislocations, traction, gentle hip flexion with a lateral force on the inner thigh. For superior dislocations, traction, internal rotation, and you may have to do some extension, maybe a bump. And you do want to prevent any kind of fracture of the femoral neck. Then sort of these short, jerky motions can be risky, and it's better to just tire the muscles out and do continuous traction. Post-reduction, you want to get x-rays. You may also want to get a CT scan. Examine the hip to make sure it's not grossly unstable. So sometimes these can be treated non-surgically if there's no fracture, for instance. So if you just have a pure hip dislocation, the hip is stable after reduction and there's a congruent joint. If there's a very tiny fragment that's recessed in the cotyloid fossa, that might be fine. But if there's a large fragment blocking concentric reduction, that's probably not fine and will need to be dealt with. You'll want to employ posterior hip precautions to prevent redislocation, and then touchdown weight bearing and follow-up x-rays. Here's a case example. 25-year-old male, motor vehicle crash, posterior hip dislocation, no obvious fracture. Alice maneuver is done, conscious sedation, and looks like it's not concentric. Maybe something's blocking reduction, but we don't really see anything obvious on CT scan. So it's thought that maybe there's some kind of soft tissue interposed, labral tissues perhaps, but then the patient gets G-day views and the hip looks reduced. So ended up not needing surgery. An MRI is obtained, and there is a posterior labral tear, but certainly nothing blocking reduction in the joint. So treated non-surgically, toe touch weight bearing for 6 weeks. So what are indications for operative treatment? Well, irreducible hip dislocations, hip dislocation with a femoral neck fracture, incarcerated fragment in the joint space blocking reduction, like shown here. You can see that fragment. It's, if it was, sitting here and small and recessed within the, cotyloid fossa and not really hitting the head, then you can imagine that might be okay. It certainly wouldn't need to be dealt with emergently, but this fragment here might be causing more problems. Or if the hip is unstable after reduction. If the hip doesn't reduce, you may need to do emergent open reduction. I mentioned in the previous video that you do have to be careful to not cause fracture by repeated attempts. Sometimes you will have a femoral head that may be impacted against the posterior wall, similar to maybe like a posterior dislocation in the shoulder. With that reverse Hill-Sachs. And what can happen is if you try repeatedly under conscious sedation, you could cause a femoral neck fracture. So this may potentially require a reduction under general anesthesia or open reduction. So what about an anterior irreducible hip dislocation? What are the possible causes? Well, could be the femoral head buttonhole through the capsule, the rectus femoris, the labrum, the psoas tendon can block reduction. What about a posterior irreducible hip dislocation? Well, could be due to piriformis tendon, obturator internus tendon, maybe the gluteus maximus, posterior capsule, ligamentum teres, maybe a bone fragment, or the iliofemoral ligament or labrum. So beware of the irreducible posterior fracture dislocation without a posterior wall fracture. So again, if there's minimal to no motion possible at the hip, then it's possible that you may have this sort of constricting capsulolabral defect. And here you can see there's a femoral head fracture, and this would be at some risk for a femoral neck fracture if you repeatedly tried to close reduce it without success. So non-operative treatment of hip dislocation with the femoral head fracture. Well, sometimes it doesn't need surgery. So if the hip is stable after reduction and you have a congruent hip joint and you have perhaps a Pipkin 1 fracture that's reduced here, if you look closely, there's a Pipkin 1 infrafoveal fracture here anteriorly, and it looks reasonably reduced. So this may not require open reduction internal fixation and can be treated like we did for our case treated non-surgically with toe touch weight bearing and close follow-up. So you might also treat this if there's a Pipkin 2 femoral head fracture that's anatomically reduced, but there is a risk of redisplacement, so you have to be a little bit more careful with these. But certainly if you have, a fracture that reduces like this, potentially you could treat non-surgically. All right, we're going to pause here, and then we're going to finish up with talking a little bit more about operative treatment of these injuries, surgical approaches, and we'll get to all that in the third and final video of this slide deck. Thanks.